Welcome to Section 5C. We will be identifying the role of laboratory science and epidemiology as we go through the section. The Global Antimicrobial Resistance Surveillance System will be known as GLASS from now on, is developed to support the Global Action Plan on Antimicrobial Resistance. The aim is to support global surveillance and research in order to strengthen the evidence base on antimicrobial resistance and help informing decision making and drive national, regional, and global actions. GLASS promotes and supports a standardized approach to the collection, analysis, and sharing of AMR data at a global level by encouraging and facilitating the establishment of national AMR surveillance systems that are capable of monitoring AMR trends and producing reliable and comparable data. A stepwise approach focusing on priority samples and on antibiotic pathogen combinations is recommended. There are three main AMR surveillance approaches described under GLASS: case-finding surveillance based on routine clinical specimens sent to the Sentinel site's laboratory, case-based surveillance of clinical syndromes at Sentinel sites, and special studies and/or surveys. In the case-finding surveillance based on routine clinical specimens sent to the laboratory, cases are found among routine clinical samples by AST of defined specimen types: blood, urine, stool, urethral, and cervical swabs from patients suspected to have a bacterial infection. However, there should be a deliberate effort to collect clinical and demographic data, in addition to microbiological data gathered in the laboratory. In case-based surveillance of clinical syndromes, surveillance data may be collected based on patients in a defined population who present for medical care with signs and symptoms that meet a specific case definition. The denominator for case-based surveillance is a defined population, such as people in the general community, patients having received specific clinical procedures, or patients with specific conditions or characteristics. For example, case-based surveillance could focus on systematic collection of a minimum dataset on a few priority conditions, such as urinary tract infection, septicemia, etc. Data on symptoms, laboratory tests, patient demographics, and history provide a comprehensive picture of patterns in resistance by patient characteristics. Special studies and/or surveys are data collection methods that supplement other surveillance methods. These may include, for example, Enhanced Gonorrhea Surveillance Program, GLASS-EGASP, GLASS Attributable Mortality for AMR Bloodstream Infections, One Health AMR Surveillance, GLASS One Health. The data should be interpreted with caution as the denominators may be significantly different for such surveys or studies. In the early phase of an AMR surveillance program, WHO recommends prioritizing case-finding surveillance based on routine clinical specimens sent to the Sentinel site laboratories. We therefore look at this surveillance method in more detail. The following are key components of Human Health AMR Surveillance Program: National Coordinating Center, setting up a laboratory network for AMR surveillance. This could include National Reference Laboratory for AMR, surveillance site laboratories, surveillance sites, and epidemiology and data management structures. A national coordinating center should be set up to oversee, monitor, and coordinate the national AMR surveillance program that includes collection and aggregation of data from surveillance sites, report writing, and dissemination of reports. The NCC function is usually undertaken by a public health institute. Other institutes may be considered more suitable, but they must have access to both laboratory and epidemiological expertise and have a defined structure for surveillance coordination and data management. The NCC should define a strategy for gradual implementation of the surveillance standards proposed by GLASS and identify a focal point for communication with WHO. Ideally, the NCC should have links to AMR surveillance in animals so that ultimately it can coordinate AMR surveillance in both human and animals, with a national focal point for AMR surveillance. At least one public health or academic laboratory with expertise in methods for characterizing antimicrobial resistant pathogens should be nominated as the National Reference Laboratory for AMR surveillance. It will be required to provide participating institutions guidance and technical support in AST and quality management, including participation in external quality assurance schemes, and to confirm unusual or new resistance patterns before they are reported to the relevant national authority. The NRL should lead the effort in establishing a case finding AMR surveillance system based on prioritized samples: blood, urine, stool, cervical, urethral swabs sent to laboratories during routine care of patients. Note: if capacity for fulfilling NRL tasks is not yet available within a country, collaboration can be temporarily established with an appropriate institute in another country. In the early phase of implementation of an AMR surveillance program in human health, it is recommended in GLASS that laboratories should start with a standardizing sample collection and processing procedures for a few sample types: blood, urine, stool, urethral, and cervical swabs. On obtaining proficiency for these sample types, other sample types may be added. The National Reference Laboratory should take lead in standardization of procedures at peripheral laboratories. This slide shows the 4 priority specimens and 8 priority pathogens currently monitored for resistance to specific antibiotics according to GLASS Manual version 1. Staphylococcus aureus, Streptococcus pneumoniae, Acinetobacter baumannii, Escherichia coli, Klebsiella pneumoniae, Salmonella species, Shigella species, Neisseria gonorrhoeae. Please also note that a country may have additional priority specimens, pathogens, and pathogen antibiotic combinations depending on local priority and epidemiological patterns. The pathogen antibiotic combinations shown on this slide have been prioritized by WHO to monitor specific types of resistance at global level. In addition to these pathogen antibiotic combinations, country-specific national pathogen antibiotic combinations may be defined by the NCC. The National Reference Laboratory has to ensure that methods for isolation and AST have been standardized across the laboratory network before entering data into the AMR surveillance database. As a priority, the laboratory request and report forms should be revised to include all patient core data like age, gender. Special attention should be paid on differentiating between community patients and inpatients who might have acquired the infection during hospital stay. Hospital or other type of inpatient care facility means patient admitted for more than 2 calendar days when the specimen was taken, or admitted to the healthcare facility for less than 2 calendar days but transferred from another healthcare facility where he or she was admitted for greater than or equal to 2 calendar days. Community patients cared for at outpatient clinics, or patients in hospital for less than or equal to 2 calendar days when the specimen was taken. Please note that the doctors and nurses should be trained on the revised forms. Generally, the minimum core patient data should be captured on a laboratory request form. Laboratories to support surveillance sites should be selected according to predefined criteria. If the peripheral sites do not meet the criteria, their capacity should be built. If required, provide staff, infrastructure, equipment, supplies, training on SOPs, revised lab request forms, and other tools, including WHO Net, a national microbiology network that links surveillance site laboratories to the National Reference Laboratory should be created. Ensure core laboratory processes, including isolate identification, susceptibility testing, either on site or through a sample referral process. Refer isolates with unusual, unexpected, or indeterminate resistance patterns to the coordinating AMR laboratory for further testing in accordance with the national algorithm, strengthen data collection, and reporting within the lab network to include core patient data. All laboratories that provide data to an AMR surveillance system should participate in a proficiency testing scheme recognized by the NRL, and the proficiency scheme should cover antimicrobial susceptibility testing. My support surveillance site laboratories to provide quality lab services and enhance data collection by provide core laboratory processes, including isolate identification, susceptibility testing, either on site or through a referral process. Work with the technical team and coordinating AMR laboratory to develop capacity, working towards participation in EQA and gaining laboratory accreditation. Support epidemiologists, surveillance officers, data officers in AMR data collection, conduct internal quality control and external quality assurance procedures. Enter data into WHO Net or other data storage analysis system. Participate in data quality checks. In many low and middle income countries, during the early implementation of an AMR surveillance program, the number of samples or isolates is usually low, making statistical interpretation of the occurrence of AMR difficult. Improved quality of laboratory tests, structured diagnostic stewardship, and antimicrobial stewardship programs usually result in increased sample volumes. Diagnostic stewardship is coordinated guidance and interventions to improve appropriate and timely use of microbiological diagnostics to support therapeutic decisions. Such efforts are directed at generating clinician interest, specimen collection, and pathogen identification, and accurate, timely reporting of results to guide patient treatment. Epidemiologists play a crucial role in AMR surveillance. They define what is required to monitor the population, analyze data to check for process and outcome measures. Surveillance teams develop and operationalize the surveillance plan. They also take appropriate measures and actions. Epidemiologists should ensure representativeness of the population surveyed, national and sentinel site catchment area. The presentation of patients to healthcare services and their subsequent investigation is neither uniform nor consistent. Therefore, it is important to understand the relationship of the population surveyed to the wider population. This is particularly important in relation to non-random sentinel surveillance. It may be appropriate to undertake cross-sectional studies periodically to establish the extent to which data from sentinel sources reflect the wider community. Epidemiologists define protocols that ensure that the numerators are correct. For reliable information, data should relate to a single episode of illness in a patient. It is crucial to avoid including duplicate results since a patient may have either consecutive cultures obtained from the same body site or cultures from different body sites yielding the same organism, for example, urine and blood culture. For microbiological data, only the first positive culture from the patient for each disease episode should be reported for surveillance purposes, even if several positive cultures are obtained or resistance emerges during treatment. This will be the reliable numerator for the antimicrobial resistance surveillance. Epidemiologists support the development of protocols that ensure that the denominators are correct. Since the submission of microbiological specimens for analysis is inconsistent and varies widely, the use of laboratory specimens and isolates as denominators produces rates that are of limited epidemiological relevance unless linked to disease incidence. Wherever possible, rates should be expressed in terms of cases within a defined human population in a defined time period. Epidemiologists define metrics that should be generated by the surveillance system. It is important to express antimicrobial resistance rates as incidence rates within a defined human population instead of using the number of isolates tested as denominators. Sometimes measurement of incidence is confused with prevalence. The next slide explains the difference between the two. It is important to know the difference between incidence and prevalence. Incidence is the rate of occurrence of new cases during a given period, day, month, year, decade, in a specified population, gender, age group, community, country, etc. Prevalence is the proportion of cases, new and old, in the population at a given time. Data collection, analysis, and report writing for AMR surveillance is at two levels: site level, national level. At both levels, the key activities are data collection, data validation, data analysis and interpretation, and report writing. At surveillance site level, data is collected from clinical laboratory, catchment population, and pharmacy data. The surveillance site team includes microbiologist, clinician, pharmacist, biostatistician, physician, surveillance officer are responsible for data collection, validation, analysis, and interpretation. Data analysis is for local level utilization of monitoring and alerting. The team may get technical support from national level. At surveillance, site level reports are sent to the Medicines Therapeutic Committee, Health Facility Senior Management Team, and the NCC. At national level, data collection, data validation, data analysis and interpretation, and report writing is undertaken by the NCC. The team consists of a senior microbiologist, physician, pediatrician, epidemiologist, senior pharmacist, biostatistician, data manager. At national level, further in-depth data analysis is undertaken to monitor trends of AMR, identify possible outbreaks, communities and health facilities, quantify burden of AMR, investigate and assess causes or risk factors of AMR, and provide guidance to the policymakers in regards to treatment guidelines and AMR prevention and control. Reports are compiled and sent to national authorities, technical working groups, One Health Platform, WHO, and other global bodies.